So I just want to welcome everybody today. You know, we've been doing this conversation series about things that we really want to be able to talk to clients well about, and particularly in circumstances where we haven't run into something before. We might not feel very well prepared to address that with a client. And so that's one of the reasons why we've been having these conversations. So I'm just inviting you guys, if there's something specific, some medical procedures, something that we're going to talk about today that you want to make sure gets covered, I invite you to put a note in the chat. You can find the chat on the control bar in the little more section. Okay. And let's go ahead and show our presentation document for today. Let me get that lined up for us. Okay. So we're talking about medical procedures, and part of the reason why I wanted to make sure that we did this specific topic is because sometimes we have really strong opinions. You know, when the truth is that sometimes our clients come in and they say, "Do you think it would be a good idea for me to do such and so?" And you think to yourself, "No, that would be a horrible idea. Why would anybody want to do that?" But we can't really say that to our clients. And unfortunately, a lot of us have been known to say more than probably was advised or advisable by our clients. And so because we have a medical legal responsibility, you know, those of us who are CHC certified are part of the national healthcare workforce. This is a serious thing. You know, we are part of a profession that has ethical standards. And so we want to make sure that we meet those standards and that we speak appropriately to our clients. Welcome, Prabha. Welcome, Allison. Welcome, Shobha. Glad to see all you guys here. Okay, so in this conversation series, we've been talking about how many of us came to homeopathy from completely different backgrounds. I was a software developer and a project manager and a computer geek. And so I definitely didn't know very much about how to have these kinds of conversations long ago. But the way that we communicate about ourselves and about our work is really crucial. And most of us didn't learn very much about this in school. And so if we're going to have effective communication that can make or break our practice, we better learn somewhere and then practice it. So today we're going to be talking about discussing with clients in a way that provides them with what they want and need, that aligns with our medical legal responsibilities, and that partners as well as could possibly be arranged with the homeopathic therapeutics that we are doing. Okay? There are times when us and medical procedures don't get along so well, and we'll go through some of my difficult experiences. Okay, so the first thing that we're going to talk about is our agenda for today. The University of Brighton did a study on what clients expected and wanted with a group of osteopaths in the UK. And osteopaths, I know, aren't the same as homeopaths, but it was the closest that we could find to something that has to do with this kind of a survey, and it has some really good information. And when this class is posted, I'll make sure to put that document there with it. Oh, let me make myself a note so that you guys will have this osteopaths survey. Okay. Yeah, it'll be posted on my website on the CEU Today page, and it'll also be posted for those of you who are listening who are on the hub. It'll also be posted within the Trinity Health Hub. Okay, so we're going to talk about this University of Brighton study. What do clients really want from us? What do they expect from us? What are we providing? Are there some gaps there? And then the next thing is our medical legal guidance. What are we supposed to be doing, really? And what are we not supposed to be doing? And then we're going to talk about how a lot of us have a lot of opinions. And an opinion is not the same as assessment and guidance. We can't say that a personal opinion and a professional opinion are the same thing. We're going to talk today about some case examples, and we're going to talk about how do you gather resources and be prepared for conversations with clients about medical procedures. And of course, we'll try and save some time at the end for you guys if you have questions. Okay? So, University of Brighton did a study in 2011 where they reached out to 800 osteopathic offices. And through those offices, they sent out questionnaires to bunches of people, and they got back 1,649 questionnaires. And of those folks, some of them, they just took the data from the questionnaire. Those who were willing also showed up and participated in discussion groups and focus groups where they were asked questions and had a chance to look more at what was going on. So there were several things that came out of this that are very interesting to us. And one of them is that they wanted very much for their practitioner to be open-minded to other therapies and to be able to advise them about what other therapies might be helpful to them. Now let's just take a pause right there with that, because there are a lot of homeopathic practitioners that don't roll that way. I remember being told, do any of you remember being told in school? Tell your clients if they're going to work with you, they have to stop doing acupuncture, they have to stop doing, these herbs, they've got to stop doing all these other things, or it's going to confuse the case and you won't know what's working. Many of you guys told that? I heard that. And you have to tell them to stop drinking coffee, and they're not allowed to use mint toothpaste, and a whole bunch of other things that honestly I don't worry about at all now. But I did at the beginning very much. And so when somebody came to see me, I had a long list of things that they were not supposed to be doing. So not only was I not well informed about other options, my first position was to tell them, don't do any of that. And if you do any of that, I'm so sorry, but I can't work with you anymore. So how effective is that approach in supporting the client? Not so effective. Do I ever lose a client when they seek supportive care? Not so much. I actually don't even lose a client when because of finances. No. Even if I haven't been able to find a good remedy for somebody and they go to see another practitioner, very often they're scared to tell me, hey, I'm not getting the outcome that I want, and I'm going to go see this other person. Usually my response is, I'm so glad, because I know that practitioner, and that practitioner is fantastic. And it's a great thing because we haven't been making the progress we would have liked for you to have a second opinion. And then I call them up a couple weeks later and say, how's it going? And then I call them up a month after that and I say, just wanted to check in on you because I care about you. Are you doing okay? And then I sort of let it go. So there are times when somebody isn't going to continue to work with me, but I still want them to know that I care about them and that the important thing is a good outcome for them. And I want them to very clearly see that I don't think that it's a disloyalty or a problem in any way. A lot of times our clients are afraid we're going to be mad or we're going to be hurt. And we need to make sure that the only purpose for the practitioner and the client to be interacting is the health of the client. So everything we need to do is in support of that. So no, I don't tend to lose clients when they seek some other kind of care. Okay, so clients want therapists, want practitioners, osteopaths, homeopaths, whoeveropaths, to be able to answer questions about the effects of previous treatment. They want us to be able to talk to them about the homeopathics they've taken. They want us to be able to talk to them about other therapeutics that they're considering. And if they're not improving, they want us to be able to say, what do you think about acupuncture? What do you think about somatic therapy? What do you think about, whatever? Okay? So we want to be sure that we are providing what clients need because it provides the best level of care. So let's start with this one of open-minded toward an array of therapeutic options. Holy moly. How many of you guys have heard the story of someone who went to see their doc with a problem X, Y, and Z? And the physician said to them, well, I don't see this working out very well. We don't really have good therapeutics. I can give you this very strong medication and we can see if it works, but you're going to have to be on it for the rest of your life. And then that client comes to see you. And then you give them a remedy and all their symptoms go away. And they're so excited and they go back to their doc and they say, Doc, I'm better. And their practitioner says, oh, that drug helped you? And they say, no, I went to see a homeopath. And what follows is 15 to 20 minutes of a lecture from the physician on why somebody should never go to see a homeopath because it's voodoo, pseudoscience, and it's dangerous. And the doc is not looking at all at the fact that the symptoms are now gone, that the thing that could never be cured and they were going to need to be on meds for the rest of their life isn't happening anymore. They're just lecturing them. We don't ever want to be that person. So if you are not open-minded toward the other things that clients are doing and you are not okay with being in a team, then what's the outcome? Clients are going to keep doing exactly what they're doing, but they're going to stop telling you about it. So we want to express to clients that we are open-minded about therapeutic options. If this person wants surgery for their back pain, then we can say, yes, surgery is an option for back pain. Acupuncture is also an option for back pain. This other visceral manipulation and somatic process is also an option for back pain. This other thing is also an option for back pain. All of those are options. And we can look at any of those in addition to what we're doing with homeopathy. That's what clients need to hear. Any of you feeling kind of bristly on the back of your neck about that? Anybody feeling like they would have a hard time saying that to a client? These clients want us to be informed about these options. Now, this is one of the reasons why it's super good to have a niche. There are some of you who have taken several different classes that I've done, and one of the classes that I talk about in the practice development course, one of the classes I talk about this idea of finding a niche, some area of practice that you're particularly interested in, that you get particularly good at. And when you have your niche, you're more likely to be informed about all the options that are related to that niche. So this is one of the advantages there. Because I'm in reproductive therapies and endocrine problems, when somebody wants to talk to me about, oh, well, what if I do this Depo-Provera shot? Okay, these are the pros and cons of that. And I can talk with them about it because that's in my niche. The clients also expect us to be knowledgeable about referrals. They want us not just to say, you know, acupuncture might be a good idea, but to connect them with, these are 3 good acupuncturists that I have a good working relationship with. This is somebody who does craniosacral therapy that I have great confidence in. This means that part of our job is to build a network of referrals of people that we're going to work collaboratively with. So clients also wanted their practitioner to inform them regarding the pros and cons of various option choices. And this included options outside of osteopathy. Now, in this particular survey, they did not go into referrals to acupuncture and homeopathy, but those were parts of future survey items that they wanted to do. So our homeopathic clients want this too. Many of our clients have been discussed with or advised about some kind of medical procedure, a diagnostic procedure or an intervention, and they're not sure. The doc says, well, we could do this or we could do this. And they're not sure. And because medicine is not their field, they may not have good resources to help them figure it out. And that's when they'll come to us and say, can you help me? So as an example, we have a client, Jane Doe, who's 72 years old. And she's been seeing you for 7 months. Now, she's a client who's from Eastern Europe. Her mom had tuberculosis after World War II, when there was, you know, a lot of difficulties there. And the client, when she initially came, reported that she occasionally had vertigo when she was rolling over in bed. Her chief complaint was problems with her right leg. She was experiencing what's called a foot drop, where the musculature and function of the foot doesn't work properly. Normally the foot picks up in a flat way. And what was happening is that her leg would pick up, and instead of the foot picking up with the leg, it would be limp. And so she would trip over her right foot. Now her foot was increasingly numb, and her lower leg was increasingly numb and stiff. So there was more to the case than this, but these were the salient important points for you. And you look at the case and you say, neurological weakness, stiffness, stuff happening in the legs. This is a woman who's got vertigo when she rolls over in bed. She's got a TB family history. And Herring, I think it's Herring, says that what thuya is to medarinum, conium is to tuberculinum. And so you look at the case and you think, let's give her some conium. Okay, now we could make up other stuff about this. This is one of my cases that I'm just putting up here as a possibility. So she's given conium LM1, and her foot drop gets better. And then by the time that she's through conium LM2, she doesn't have any more vertigo, and she's happier than she has been in ages, and her energy's come up. And by the time that she's through conium LM3, she doesn't have any stiffness anymore. And by now it's like 4 or 5 months in, and she comes back and she says, I feel great. I feel great. And you say, great, let's wait. Let me know if you need anything. I'm here for you. And so she goes off about her business. And a few months later, you get a call from her. And she says, oh my goodness, I had my annual physical exam and I had a mammogram. Now, this right away should make some red flags go off. The woman is 72. What are the best practice guides for mammograms over 70? I believe that they say that there's no benefit at that point. So right away I think, why are they giving a 72-year-old woman a mammogram? What's going on there? And then she tells us that they found a lump. Oh dear, a lobular nodule in the upper outer quadrant of her left breast, and it's the size of a little cherry pit. And so they say, oh, we have to biopsy this. And all this has happened right away. We have to biopsy this. So they do a needle biopsy and they say, oh, this is an estrogen cancer. And the tumor is given the marker size of T1, which means it's less than 2 centimeters. It's little. This is little. It's like less than an inch. So the client says, my doc has referred me to an oncologist who referred me to the surgeon who wants to schedule the surgery right away. And this surgeon is saying that we could do a lumpectomy, but actually the safer option is to do a full mastectomy and then do reconstructive surgery afterwards. And I'm listening to this thinking, this is for a stage 1 cancer that's less than 2 centimeters? And they're talking mastectomy? And all kinds of red flags are going off. But I'm listening. And then the client says, and the doc said that radiation is very likely, that that's the standard procedure in this kind of thing. Am I going to need to do radiation? Should I be considering a mastectomy? Do you guys get these calls? These clients are worried. They're scared. They don't know what to do. And they are being told by a huge authority. The conventional medical system has massive authority. And so this woman who's 72 is being told at least a lumpectomy, radiation is likely, and a mastectomy would be a good option for you. And she doesn't know what to do. So she comes to us. Now, what is our role in this? Our role is to be her advocate, to help her navigate holistic, healthy options for her. So we're going to go through some other information and then we'll come back. We'll just leave Jane Doe sitting over to the side, vaguely panicked because she's not sure what to do. Okay? So when she asks us, what should I do? There are medico-legal realities that we must remember to address. The first thing is that we need to remind our client, I'm not a doc. I do not diagnose and I do not treat. I just, at the outset of our conversation, I need to remind you, I'm not a physician. So for those of you who are watching it who are physicians, obviously you don't have to say that, but I have to say this. I'm not a physician. I don't diagnose and treat. And the second thing that I need to say, and this is just making sure that we cover our medical legal responsibility. I need to communicate my professional code of ethics, and this is for all the people who are CHC certified, all of those of you who are part of the national healthcare workforce because you're a CCH homeopath. This is in your code of professional ethics. So if you've got any questions about it, go download the code of ethics from the CHC website. It's what you're asked to agree to every time when you renew your credential. My professional code of ethics prohibits me from ever suggesting that anyone stop a therapeutic plan established by your physician. And so I do not now, nor will I in the future, suggest that you stop or alter any plan that you have entered into with your physician. Okay, we just have to get that out there right up front, guys. And these need to be statements that you practice so that they come off your tongue easily. And then we say, here's what I can do. I am able to educate about the therapeutic options that may be relevant. And I am glad to connect you with resources and information so that you can feel confident about making the right choice for you. And the third thing is that we want to make sure that the client feels our support. And so we want to offer them compassionate care statements. This client, our poor Jane Doe, who's 72 years old, who now has this little lump, and guys, what remedy was she on? Canium. Canium has this weakness of the breast. So now we are going to ask her a zillion questions like, did you ever get bonked in the breast by a baseball? Did you ever whack your breast against a steering wheel in a car accident? Was your breast ever injured in that area? And we're going to try to find out other things homeopathically. But first, we have to help her deal with the fact that she's totally freaking out, that she may be facing a mastectomy and radiation and she doesn't know what to do. Okay? So the last thing that we're going to say to our poor freaking out client is, I hear this sounds like a very challenging time with you. And then we're going to offer reassurance. I'm here with you. I'm here with you. And we will work together as you go through this. These two statements are crucially important. So this entire script, very important. What are we not doing? What are we doing? And how are we in service to the client? Do you guys say these things now to your clients? Are these conversations that you're having now? These last two statements especially are crucially important, okay? So this whole document will be available for you to download with the recording so that you can just print this page out and stick it in your clinic reference notebook. All of the statements are going to be available for you. Okay, so the next thing is that opinion and my preference is a different thing than assessment and guidance. Let's get clear about what is the client really asking. The client is seeking your guidance to help him or her make the best choice possible in a scary, unfamiliar terrain. The client is also very likely to be seeking reassurance. I'm scared. Bad things are happening. The sky is falling. The sky is falling. Will you help me? Okay? And they may ask questions in order to be reassured that don't necessarily look like reassurance questions. Okay? They also may be seeking adjunct care. Holy moly, if I have to have radiation and my hair's going to fall out, is there a remedy you can give me to help me? Okay? And so one of the very best questions we can start with in order to clarify what is the client really asking us for is this one. After we've said all this, I'm not a doc. I am not going to tell you to stop anything your doc has asked you to begin with. I am able to educate. I'm going to help connect you with resources so that you can feel confident about making your right choice. I hear you're uncomfortable and we're going to work together and I'm here for you. The next thing that you say after all of that, how best can I help you in this situation, Jane? And what the client is not asking, even if it looks like it, is what would you do? And this is never, ever appropriate for us to answer, even though it's going to be one of the first things we want to say. And that is our opinion about what we would do for ourselves, and that is 1000% irrelevant for this client in their life at this time. Keep your opinion to yourself. Your opinion about this for yourself is no more relevant to them than your opinion about what color couch should go in your front room. It's just an opinion. All right. So the client may ask, what would you do if you were me? What would you do, Karen? What would you do, Mary Beth? What would you do, Allison or Prabha or Shobha? What would you do, Janet? What would you do, Carrie? If you were me? And the client here is actually seeking reassurance. I want to do what a wise person would do. I think my homeopath is wise, so I'm going to ask what they're going to do. But it is inappropriate for us to reveal what we personally would choose, which can then create all kinds of bias and expectation. What if we say to the client, oh yeah, I would do that, and then they decide not to? They're going to be afraid that we're going to be, all the carcinosin ones would be super afraid. Oh, I made a different decision than what my homeopath who I love said, and now she's going to be mad at me because I didn't do what she said. There is no point in putting that stress on that client. Or what if they do something where you said, I would never do that. And now they're like, oh my God. And now if it goes badly, maybe she won't help me. This just creates a huge amount of stress for them that's not in any way appropriate, because our opinion about it, the only expressed opinions are the things we already said. So when the client asks us, what would you do if you were me? Here are the answers. What I would do is what I'm doing now. I'm helping you to look at your options. And you just completely ignore the question. I'm glad to talk with you about this. Do you have specific questions about this procedure or your condition or, something your physician said or whatever? Okay, second possible response. My professional code of ethics guides me to keep my personal opinions and my professional assessments separate. So let's talk about helping you find the right choice for you. Are these statements that you guys can see yourself using? You can see how these allow the client to get reassurance from you without creating the potential for them to be wrong in your eyes, which just adds another level of stress to them. Okay? So let's talk about a few times when I went through this and it went badly. Early in my practice, I had a client who had gotten pregnant, and I'd been practicing maybe 3 or 4 years. I went to a client a client came to see me who had gotten pregnant, and when she went in for like a 12-week checkup, they listened for the heartbeat and there was no heartbeat. It was sad. And the doc said, well, we can do a D&C, or we can just wait for you to pass. Your body will register the fact that the baby's no longer alive and will discharge all the products of conception, and there you go. And kind of left it up to the client. What do you want to do? So the client came to me and said, what do you want to do? What should I do? And I went through these steps and I said, I'll be here with you. I'm not allowed to, stop anything that a conventional doc has told you to do. And I'm not a doc and I don't diagnose. And how can I help you? And basically what she said is, I am miserable thinking that my dead baby is inside me. And I want it out right away. And I said, so if this is true, I want you to go talk to your doc and say, this is how I feel. Can we schedule a D&C right away? So, and I say to the client, here's some arnica. Here's a little vial of 200C arnica. And as soon as you get out of the room, you know, and you're recovering from having the DNC, the dilation and curettement, which basically means the inside of the uterus has been scraped. I want you to take a dose of 200C arnica. Okay, so this was where I was trying to do something helpful and supportive, but the reality is that arnica speeds granulation of tissue and promotes clotting. And that's really not what you want on a scraped endometrium. You really want the endometrium to heal in its own special way. And this client ended up with horrible, horrible cramping and then passing these enormous thick clots because arnica promotes clotting and granulation of tissue. And I felt horrible. And I didn't say to the client, you know what, that was a big mistake on my part. I will never do that again. But I have never done that again. So when we are thinking about how do we support the client with these medical procedures, we need to be cautious and wise about how homeopathy is going to interact with this stuff. Okay? Have some of you guys had similar circumstances where you tried something, it seemed like a good idea at the time, but homeopathy really didn't help in the way that you had hoped it might? Okay, well, so let's go on. We're going to gather resources for each of us based on our niche, based on the things that we are most likely to see for the clients that we work with. So we have to ask ourselves, what are the medical procedures that my clientele is likely to be dealing with? Diagnostic procedures to diagnose or confirm. Lab, you know, things like a barium enema or a radioactive iodine evaluation of the thyroid, or any number of different procedures, a laparoscopic evaluation for endometriosis. And then there's simple lab tests, blood tests, urine tests, saliva tests, and there's things like an MRI or an X-ray or a CT scan with or without contrast. And contrast means that something's being injected. So after the person is done with the procedure, can we give them some Nux vomica to help their body detox from that? Yes. Can we advise and talk to them about a CT scan? A CT scan of somebody's head is the equivalent of, I can't remember the exact number, it's either 75 or 100 X-rays. It's that level of radiation. And so when somebody says, my doc wants me to have a CT scan, a lot of times I'll say, is it possible for you to get the information that you need with an MRI? And an MRI has no radiation. It doesn't have the downside of a CT scan. So when we are advising clients about procedures, sometimes we can help them clarify what really is needed. So other procedures, exploratory surgery or off-label meds are things sometimes that clients come, my doc is suggesting that I take this thing. It's actually for that, but this is sort of an experimental use for it. I don't know whether this is a good idea or not. What do you think? So we may end up doing research for our clients on behalf of some of these things. Clients may come and talk to us about having booster vaccinations or travel vaccinations. And Lord knows there are a lot of homeopaths with very strong opinions about that. Or elective plastic surgery. Oh, I have this mole and I'm thinking about having it taken off, or you know, I'm 64 and now my eyelids are getting a little droopy and so I want to have that done. You know, just a little bit of, you know, clients come and talk to us, what do you think? Is there any downside to doing that? And clients come and talk to us about all those kinds of things, about a bunion surgery, about all kinds of stuff. So then we have to step back and say, what do I need to know in order to advise? Now, remember, we do not diagnose and we do not treat. So it's not even our job to say, does this thing apply to you or not? The doc has already done that. What we're saying to the client is, what should you be thinking about? What other questions can you ask? What other options can you explore? Okay? So what do we need to know in order to advise them? We need to know what is the actual process and sequela, typical sequela of the procedure that is being recommended for them. If somebody's recommending a barium enema, then we should be able to tell them this is what happens with a barium enema. We should be able to become familiar with what are the common side effects and what could go wrong. And, you know, when I first started homeopathy, this was not easy information to find. And now it is everywhere and easily learnable from reliable websites in a few minutes. So you can say to the client, tell me what it is. Let's make a time tomorrow to talk about this. And you can be fully prepared. You also want to be able to advise them about contraindications, and you want to compare whatever possible difficulty from this procedure might be running into information that you specifically know about the client. Do I charge for these conversations? Absolutely. This is a consult. Yep. I say, let's make an appointment to talk about that. Now, I don't usually charge for my research time unless there's something quite intricate. Because I've been doing this for long enough now that I've got an awful lot of notes. It's unusual now that every once in, like a couple of months ago, there was a client, well, last year, I had a client who had some kind of really weird robotic surgery that I'd never heard of before. And I did quite a bit of research about that. But in general, it doesn't take me very long now. And so whatever you learn, you'll learn it then and have it documented so that every time you get asked that in the future, you just have to go out and see, oh, has this been updated? Has it changed over time since I looked at it 6 months ago or a year ago? Okay? All right, so how do we find out this stuff? Well, this is one great website. There's also websites on the Mayo Clinic. This is the first one that I go to. And this is the Harvard Medical School Diagnostic Tests and Medical Procedures Library. So this is free and out there for everybody. And you can go right out here, pull up one of these things, like let's say that your client has come to you, you have a pregnant client and they're saying, we want to do an amniocentesis. And the client says, I think that means a needle into my uterus and I don't like that. Okay, is this a good idea? And so right away, you can make an appointment to talk with your client about it. You can come out here, you can read about it. You can go further into other places. A lot of these have references for other information. You can go out to PubMed and the CDC and the National Institutes of Health, and you can find pros and cons and risks and contraindications, and you can gather all that information up. And when you have these resources, then you can make like a report for your client where you've got these different links. And you can say, please do this reading. I'm educating you about this. Now, most of the time, the clients probably aren't going to go read all that, but some of them will. And because you are quoting very respected resources, your authority goes way up in the mind of the client. Oh, Mary Beth, when I went to her, or Allison, when I went to her and I asked her about amniocentesis, she provided all this information. She was just fantastic. She helped me walk through it and become familiar with what the procedure is. And she was so caring. She said, I know this is hard for you and I'm gonna be right here with you. We're gonna go through this together. And it just made my heart feel so good. All right, that's the kind of response you want with your client. So this is my first stop. And all you have to do is go Google Harvard Medical School Diagnostic Tests and Medical Procedures, and it'll pull this page up, which goes way long because they've got more than, it says right here, more than 110 tests and procedures. And then just bookmark it in whatever browser you use most so that you'll have it there. Okay? Now, this is just one of many of these kinds of directories. The Mayo Clinic, Johns Hopkins, the Cleveland Clinic. There are a lot of different respected groups. For cancer procedures, I often look at MD Anderson. Okay? So just find for your niche, let's say that you work a lot with concussions. You're going to find the resources that are state-of-the-art best practices for concussions. Let's say that you work with seniors who faint, and then you're going to work with best practices around syncope. Or maybe, you work with babies who have problems after vaccinations. You're going to find the best resources for whatever it is that you're the one doing, okay? So what do we want to do after we've gathered all these resources and we're familiar with the procedure? We've looked at what are the risks, what are the pros and cons, what's the unique kind of information that this is going to give to us, that it's going to give to our client, give to our client's physician. Then we have to ask ourselves, is this typical? Is it typical that our client in the client's current scenario is having this medical procedure or intervention advised? Is this typical? And so you can do some research and find out, are there contraindications? Is your particular client's circumstance within those contraindications? Does best practices for your client and their complaint follow the guidelines of what your client is coming and asking you about? Now, as an example, let's say that we have someone who is an autoimmune client, someone who maybe has any number of autoimmune conditions, Hashimoto's thyroiditis or Sjogren's or psoriasis, severe rheumatoid arthritis, something that is an autoimmune thing. And the client has been having some kind of recent immune challenge, like recurrent colds or bronchitis. And their doc has advised them to take CellCept. And the client comes to you and says, I don't want to take this, but my doc has said that he or she thinks that CellCept is going to help me. Now, my job in that position would be to go find research on outcomes of CellCept in immune-compromised clients that have the same kinds of complaints as my client, and then provide that information to the client and say, based on this, it does not appear to me that this is after I've said all that other stuff. I don't diagnose, I don't tell you to stop taking it, and I'll be here with you and I'll walk through this with you. And here's this information. What I would suggest is that you go back to your doc and take this information and ask your doc to explain why in the current immune-compromised circumstance that you are in, an immunosuppressant like CellCept is the best option for you. And clients will write out exactly these questions and take them back to their doc. Now, we're helping them find out. We're not telling anybody what to do ever. Do you see how we're doing this? Do you see the strategy involved? Okay, so let's say that we have an 85-year-old client with a history of atrial fib who has been having tachycardia, recent events of tachycardia, very, very fast heartbeat, feeling very jittery. And the client's doc suggests, well, let's just check out your heart. Let's do a treadmill test. Okay, so for this client, for an 85-year-old client with a history of heart problems, is a treadmill test really the very best option in order to explore the tachycardia? Probably not. So we can go find this out by saying, we can go do research, treadmill test, contraindications. It says right there in contraindications. So what's likely is that the doc either doesn't know or has forgotten that the client had AFib. And so you print out the contraindications and you give it to the client and you say, this would be great for you to talk with your doc about. Are you sure that your doc knows about this particular history? Why don't you go back and talk with your doc and see, do they have a different option for you based on this? Okay. What about a client, a 62-year-old client, a male with an elevated PSA? Now, you want to see the PSA below 2.5 in younger men, below 4 in older men. 5.2 isn't outrageous, but the client comes to you and says, based on this, first time reading out of range, my doc says that he wants to do a prostate biopsy. Should I do it? So that's an interesting thought. So what do we do about that? How do we find out? I'm going to show you guys an infographic. Because what we're looking at here is best practices. Okay, so what I did was give the client this document and said, I want you to go over this with your physician. And honestly, guys, a lot of times the physicians that are recommending these things, they're just not quite up to date with current practices. Lord knows they have a hard job and they are busy with clients all day long, and they may or may not be up to date with the latest and greatest news. So let's help them. Let's be in service to our client and be in service to them. Okay, so the U.S. Preventive Services Task Force recommends that for men 55 to 69, the PSA-based screening should be an individual one. This means we don't even think everybody should do it. Do I charge for doing this kind of research? This is the same thing that I talked about before, where the client said, I've been asked to do this. Can we talk about it? And I've said, yes, let's make a consult. And so I found this infographic and I had the appointment where we talked through it. Okay. All right, so out of 1,000 men who are offered a PSA test, 240 are going to get a positive result. And many of these men will learn that they have a false positive result after the trauma of a biopsy. And the potential side effects of the biopsy are pain and bleeding and infection. And of those 240 who get a positive result, who have a biopsy, 100 of those are going to get a positive biopsy. And 20 to 50%, up to half of those, will never be they'll be diagnosed with a cancer that never grows, it never spreads, it never harms them. And this is also known as overdiagnosis. And the best comparable thing I can offer to you is all of those women who were diagnosed with DCIS as a breast cancer and had mastectomies, and now DCIS isn't even considered a form of cancer, it's a watch and wait. So up to half of these guys will never have anything related to that that will bother them. And of those 100 guys with a positive biopsy, 80% will choose to have surgery or treatment. And the treatment could be right away, or it could be after it gets watched for a year or a month or whatever. And what happens after that? Well, most of them have some kind of major loss of sexual capacity, and about a third of them are going to end up with urinary incontinence, which causes a huge problem. It means that their clothes smell like urine, and they're no longer comfortable going into social settings. So, and out of that 1,000 guys who do the screening, which is not everybody, and out of the 240 who get a positive result, and the 100 who get a positive biopsy, and 80 who choose to do something about it, 3 of them will actually avoid cancer that's spreading to other organs. 1 of them, 1 out of 1,000, will actually avoid death from prostate cancer, and 5 will actually die from prostate cancer even after the surgery or the treatment, which means that nothing that they did intervened. Okay? So, to have this guy, after the first reading, be advised to have a biopsy, it's not in line with current medical thought, with current best practices. Okay? Now, we don't have to make this stuff up. It's out there. And it's not hard to find. Questions about that? Have you guys seen, do you guys have some of these kinds of charts or reference tools in your own library that you've used? We'll have to build a library of these on the hub that people can grab. I'll post all the ones that I'm talking about on with this recording. Okay, so let's go back to our document. All right, so then you have to ask yourself, do you know something about your client that suggests an ill effect of this procedure? If so, then you need to let your client know. Well, you are an immune-compromised person, and CellCept might be a problem, or you have AFib and a treadmill test might be a problem, or this is the first time you've had an elevated PSA rating, and most times what I hear about best practices is watch and wait. So here's some documentation. Can you go back and talk to your doc? All right, so let's go back to our client with stage 1 breast cancer who's being advised to consider radiation and chemo, who's being advised on the advantages of mastectomy over lumpectomy. So how do we research? We go and we look for very early cancers for clients in their 70s. And what do we find? We find very good research from the National Institutes of Health that says radiation doesn't help these clients. We have 0 indication that radiation is useful in this cohort. For women over 70, it is not useful. Every study shows it's not useful. Okay, so we grab that information and we provide it to this client. How do we stay within our ethical guidelines and medical legal prudence? By saying, I want to make sure you are well educated about this. Here is information you can take back to your doctor. How do we serve the client as an advocate? Well, we give them good questions to ask and help them explore from an empowered place. So let's look at some useful phrases. All of these are things that you're going to want to say to clients. Let's clarify some questions that you can ask your practitioner. And the first question that I usually have people ask is, exactly what information will this diagnostic procedure give you? When somebody wants to do the CT scan with the contrast and all that kind of stuff, Exactly what is it? The specific thing you need to know. What is it? And then I also ask them to say, is there a less invasive procedure? Something with no contrast? Something with no radiation that will also give you that same information? And then I ask them to say, will the therapeutic plan be the same whether you have this data or not? Let's say that you couldn't get me scheduled for a CT scan. Would you have me do the same therapeutic plan, the same drug, the same surgery, the same PT, the same whatever, whether you had that documentation or not? Because a lot of times physicians are doing these procedures to make sure that they are doing a CYA. They want to make sure that they're covered and that nobody can come after them. And it's not for the benefit of the client. It's defensive medicine. And I'm not interested in getting extra radiation for me or for my clients so that the doc can be covering their position. So another great question is, what would happen if this procedure's not done? If this weren't possible? If insurance wouldn't pay for it or I wouldn't do it, what would you do? What would we do instead? These are all great questions, and encourage the client to ask these from a place of innocence, not from a place of challenge. Remember that your doc is working for you and trying to help you. Keep reminding clients of this. You don't want them to go back and treat their doc like he's being a jerk and trying to damage them. You want them to partner well. So set the stage with that expectation. That they go back in and they say to their doc, I really appreciate how much you're trying to help me. And there's some things I'm a little confused about and a little cautious about. And so I have these questions. And I'm hoping you can go through these with me so that we can work well together and coach them on how to have that conversation. All right, so the second thing is that I say to the client, let's get good support for you. Do you have someone who can go with you to your appointments? Like this 72-year-old lady who's got the stage 1 breast cancer, who's being basically terrorized with the idea of radiation, which isn't appropriate for her. She's going to be scared to death in that consult. And she is not going to think clearly. And even if she does remember to ask the questions, she's not going to remember what somebody says to her. So you have to encourage them to get someone to go with them. Do you have someone who can go with you to your appointments? Preferably someone who's not intimidated about the medical system. Someone who can be a note taker, a question asker, a listener. Some docs are very uncomfortable if you pull out your iPhone and say, I'm just going to record our conversation because I know I'm not going to remember it well later. You don't like that. So I wouldn't recommend that you tell your client to do that, but having somebody there to take notes is a good idea. And then when I feel like someone is being over-doctored, like this poor little old lady in her 70s, I think she's being rather aggressively doctored. And so in a case like that, I will say, how would you feel about getting a second opinion? Is there a specialty center that's available to you, that's in your insurance network or that's nearby you or whatever, where the latest research and the most current best practices are likely to be in place? Now, notice I haven't said, it looks to me like your doc is over-doctoring you and is probably not up on the latest and greatest news. I have not said that. We are obligated not to speak in any kind of disparaging way about any other practitioner. But this says, here's what you want. You want somebody that's got these qualities. Can you get a second opinion? And then the third thing you can ask, how do you feel about your doc? Do you have a good working relationship with this physician? How do you feel about the level of proactivity? Or sometimes people are worried because their doc's not doing anything. Or they're feeling like, the treatment plan is very aggressive. Or the intervention seems very over the top. So ask them, encourage them to talk with you about this, okay? And then there's phrases that we should never let these things come out of our mouth. And I've said all of them. I'm embarrassed to tell you, but I've said all of them. Well, if it were me, I sure wouldn't do that. Oh, I cringe thinking about this. Or I think your doctor is really out of line here. That's bad. Oh, wow, I'd be really scared if I had to do that. And that in clinic one time, one of the students started to go into this whole discussion about having to go into an MRI tube and how she had a panic attack and couldn't stay still. And it's like, no, stop, time out, none of their business. What are you doing? So we don't, no horror stories from our own healthcare. Thank you. Do you really think you could make it through that? We don't want to say that. Why would you want to do that? We don't ever want to say that. Well, you probably won't have anything really bad happen if you do that. We don't ever want to say that. Well, whatever comes out of it, we can just clean it up later with homeopathy. Okay, we don't want to say that either. First of all, we don't know what's going to come out of it, and we don't know that we can clean it up. And this creates client expectation, first of all, that a bad thing is going to happen, and secondly, that we're going to be on the hook for it with responsibility to repair it. And we also don't ever want to say, if you do this, then I can't work with you anymore. I'm not going to work with you anymore. It would confuse the case. And then I wouldn't know what was working and what wasn't working, so I just can't. We don't ever want to say that. This client is coming to us vulnerable and in need. We might eventually later say, this is confusing and I'm not clear, and I'm going to refer you to blah, 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 because I can't feel sure about how to work with you. But it can never be like, oh, if you do this, it's your fault, I'm kicking you out. Okay, do you see the difference? So our takeaway from this, skills development. You want to get really clear on what clients want. You want to read the University of Brighton study. You want to consider specific implications for your clients. You want to get very clear on what your medical legal obligation is. And in this, you have to be absolutely clear that a professional assessment, what we've talked about, what is the procedure about, what are the pros, cons, contraindications, and risks and sequelas? How does that match what I know about the client in a way that is likely to be helpful or not so helpful? How can I provide information about that to the client so that they can deal with it in relation with their doctor? I am just in the advisory role. And while I'm in this role, how can I reassure and compassionately express care for this client? That's it. And that is not the same as expressing an opinion. It's not about you. It's not about your preference. And you should not be putting anything personal about your opinion that the client later can feel like, oh, she's going to be angry because I didn't do what she would have done. We are going to be educating the client, not decision making. We are never telling the client, don't you dare do that. Never. Okay, and then we want to gather resources for them so that they can be well informed, and we want to be well informed. So anything that is within your practice niche, I want you to learn about common procedures and risks and benefits. I want you to create appropriate documentation that you can share with clients. Okay, so what do you think? Do you guys feel ready now to swap opinion for actual assessment? Do you feel like you know how to research and gather information, what kinds of things you would want to gather and where you might go looking? Are you clear about how to stay within your appropriate medical legal scope as a homeopath? Questions? What do you think? Thank you, Allison. I'm glad it's been helpful. You know, there are so many of these things where until we run into the situation, we just don't know what to say and we don't know what we ought not to say. And I said so many wrong, bad, dreadful things before I knew, and I feel embarrassed. And there's some of those cases where I'm glad it's past the 7 years where they can't come back and sue me for anything because I didn't do it right. But now I do. And now as our profession grows, we can be more ethical. We can be more appropriate. Yeah, Mary Beth says it does take biting one's tongue. Yeah, golly, yes. If they're on steroids and they ask about homeopathy treatment, what to answer? My clients who are on steroids, some of them are long-term and some of them are on them for a short-term intervention, and I'm working with them homeopathically anyway. One of the things that Roger Morrison says is that within your first 5 years of practice, you shouldn't work with clients on steroids because they change the symptoms too much. Once you've been practicing for, 10 years, take those cases. You'll be able to figure it out based on what it looked like before and what's going on in the dialogue of the vital force. So, I have clients who are doing great and then they hit some kind of asthma crisis and they're on steroids for a little while, and then we go back, while they're dealing with whatever they're dealing with, they clean that up, and then we go back on our merry way. So if someone who I have not worked with me before calls up and says, oh, I'm on prednisone, I usually refer them for acupuncture. It's just hard to get a clear case. Yeah, Mary Beth says if you turn away everybody who's on significant meds, you have a thin practice. Yeah. You won't be helping those who really can be helped. Yeah, the thing with steroids is that it just alters the symptom picture so much, but there are a lot of other kinds of meds that aren't quite that disruptive. Topical steroids, you're talking about like cream, like corticosteroids for skin. That's a great question. I don't worry about it. Lynn Amara has lots of opinions about it. So Prabha, if you're on the hub, there's probably 10 hours of Lynn Amara's Skin with Lynn stuff where she talks about all of the different options for that and how she advises clients and things like that. For me, I don't worry about it. I always see topical steroids as a short-term intervention, and I explain to the client that we are in it for the long haul. And as they get better, they just don't need to keep using them. Okay, guys, thank you so much for joining in today. I will share the link if you go to my website, KarenAllenHomeopathy.com, and look on the menu item CEU today. This will be up there tomorrow, so you can find it there, okay? And you'll be able to look at the recording and download the documents. All right, guys, have a fabulous day, and I will look forward to seeing you at another class in the future. Bye-bye.